I'm Tanush Gupta. I'm an interventional cardiologist with expertise in structural heart disease interventions, and I'm an assistant professor of medicine at the University of Vermont Medical Center in the United States. The FDA approval for TAVR and asymptomatic severe AS represents a paradigm shift in treatment strategy and pathways for patients with asymptomatic severe aortic stenosis. Prior to the results of the early TAVR trial, our contemporary practice included waiting for symptom onset in patients with severe aortic stenosis. Even prior to the trial, the guidelines did allow for treatment with TAVR or surgery in a select subset of patients who had asymptomatic severe AS. These included patients who had very severe AS, elevation in BNP levels, or some high-risk echocardiographic features. However, the FDA approval expands, TAVR now to almost all patients with asymptomatic severe aortic stenosis. In the last 5 years, there's been this emerging concept of cardiac damage in aortic stenosis, which refers to downstream effects of aortic stenosis beyond the aortic valve. The new approval allows for TAVR to be performed before irreversible damage happens to the left ventricle and other cardiac structures. I do believe that with the results of the early TAVR trial and the FDA approval, there is going to be a guideline update allowing for TAVR in asymptomatic severe AS, which eventually would lead to increase in overall TAVR volumes and then more demand on cath lab time, space, and personnel. Before, I would say even a few years ago, when patients used to come in the valve clinic, they used to ask, how much is a TAVR valve going to last? And we did not have any long-term follow-up data. So we used to quote them, okay, we have information now available to 3 years that these valves last as long as valves put in via open heart surgery. However, the 10-year results from the Notion trial changed that. So the Notion trial randomized 280 patients who were low risk for surgery with severe aortic stenosis to TAVR or surgical aortic valve replacement. At 10 years, the trial showed that there was similar risk of death, stroke, or myocardial infarction between TAVR and surgery arms, and valve performance or valve degeneration, either structural valve deterioration or non-structural valve deterioration, was in fact lower with TAVR than surgery. The rates of bioprosthetic valve failure were same between the two arms. So I think these data are very important to inform discussion with AS patients, especially those who are low risk, about long-term outcomes after TAVR. And we can confidently say, based on this one trial, that TAVR performs similar to surgery out to 10 years. To support these data, we now also have 5-year follow-up data from both the US pivotal trials, that is the PARTNER low-risk trial, and the Evolute low-risk trial, and the results are in line with what was seen in Notion, with similar rates of clinical outcomes and similar or better valve performance with TAVR than surgery at 5 years. Yeah, so overall, TAVR's faring very well head-to-head with surgery, and these data help us, inform patients better and sort of allay some of their concerns about long-term valve durability with TAVR. So some of the exciting technologies include, incorporation of AI into CT scan workup. So there are two companies which I have worked with, DASI and FIOBS. Both these companies allow for predictive modeling for how a TAVR valve conforms to a patient's anatomy, and also allow for predicting some of the adverse outcomes that can happen after TAVR, such as paravalvular leak, permanent pacemaker, or annular rupture. These simulation models also allow for planning a second valve. So I think in the context of lifetime management and low-risk patients, at the time the patients come to see us, not only do we want to plan the first valve, but we also want to be able to tell them whether a second TAVR in the future, if the first one were to fail and if they live beyond their valve, would be feasible. And these CT models allow for us to do that. In terms of technology, to advances that I'm excited about is in the next year, I think we should see launch of the Sapien X4 valve. Based on results of the Alliance trial, this valve does allow for both commercial alignment with the balloon expandable Sapien platform and bespoke sizing. In terms of the self-expandable Evolute platform, the latest iteration of the valve allows for commissural alignment, and it has larger cells for coronary access. Both of these technological iterations are important in the context of low-risk patients, both allowing for coronary access after TAVR and optimizing feasibility of redo TAVR. These are the both technologies, both from a CT-based AI standpoint and a device standpoint that I'm excited about. So there have been a number of trials in the last 5 years that have looked at optimizing antithrombotic strategies after TAVR. So the two trials, that have affected my practice, like one is the popular TAVI trial from a few years ago. This trial compared, it had two arms, so it compared aspirin compared to aspirin and Plavix in patients who did not have any independent indication for anticoagulation. And in patients who had an indication for anticoagulation, the trial compared aspirin on the background of oral anticoagulation versus oral anticoagulation alone. And the results of the trial favored the less aggressive antithrombotic a strategy in both the arms. So in patients without an indication for anticoagulation, aspirin alone reduced bleeding compared to dual antiplatelet therapy without increase in thromboembolic events. And similarly, in patients who required anticoagulation, anticoagulation alone was associated with lower bleeding compared with anticoagulation and aspirin. The second trial I would mention is the Galileo trial. It compared rivaroxaban plus aspirin compared to aspirin alone in patients after TAVR. This was a large multi-center study, and surprisingly, this study showed that patients who received rivaroxaban on a background of aspirin had more death, thromboembolic events, and bleeding compared with aspirin alone. So how these studies have influenced my practice. In patients who do not have any indication for anticoagulation, we treat these patients with aspirin alone. And in patients who have an indication for anticoagulation, we continue their oral anticoagulant without adding aspirin. So these are strategies, to optimize bleeding risk in these patients. We discussed this before, but the Notion 10-year data and 5-year follow-up data from the partner and Evolute low-risk trials do inform us, of good, medium-term and long-term outcomes with TAVR, good valve feasibility. So we can be more confident in, telling patients that, the valves last as long as surgical valves, and this helps reassure them of the index treatment strategy. The predictive CT simulation now allows for us to tell whether a second TAVR valve is feasible. So in context of patients who are young and low risk, who likely require a second valve during their lifetime, we would simulate a TAVR and TAVR valve in there and discuss these images with the patient and tell them whether this is feasible or not. Also, I think we have now realized with more experience with redo TAVR that a TAVR and TAVR is feasible in most patients. And data on index TAVR durability, predictive modeling for second TAVR, and increase information on feasibility of a redo TAVR is important now in multidisciplinary decision making and informing patients of lifetime management options. One point I would like to make that despite these advancements, in young patients, especially those who are aged less than 60 or 65 years, there remains a very important role for mechanical valves and the Ross procedure in a select subset of patients because if they do get a bioprosthesis, there is, a definite likelihood of aortic valve reintervention. So if patients emphasize avoiding aortic valve reintervention in their lifetime, mechanical valves do remain an important treatment option in these patients. So I think in the next 10 to 15 years, TAV and TAV or redo TAVR is going to become a very prevalent procedure. There are predictive models that estimate that up to one third of all TAVR procedures will be a redo TAV. Uh, Coronary obstruction and sinus sequestration remain barriers to uh, redo TAVR being feasible in a good proportion of TAVR patients, and there have been a lot of iterations in leaflet modification strategies to optimize redo TAVR and increase the proportion of patients who are candidates. An exciting technology that has recently been FDA approved is called a shortcut device by Cardia, and I'm excited that there are dedicated leaflet modification or cutting devices that allow for redo TAVR in a safe manner. In the field of transcatheter electrosurgery. In the last few years, a procedure called as the unicorn procedure has been described, allows for leaflet laceration and splitting in a more streamlined manner than the traditional basilica procedure. So that's been an exciting uh, development in which affects lifetime management of these patients. In terms of devices in the future that I'm excited about, one of the TAVR technologies I'm excited about is the DuraVar by Antares, and this valve has a novel technology that involves a single leaflet tissue and has more biomimetic flow characteristics. So we'll see whether these iterations on the bench translate into more durability in patients.